Dr. Malkin, it looks like we're set to go. So,
Okay,
thank you.
good. Well, good evening, everyone, and thank you for joining us. This is the first time that we've done this event. The purpose is to let you all hear about exciting advances in neuro-oncology from our team dedicated to a interdisciplinary and comprehensive focus. As some of you may be aware, this is Brain Tumor Awareness Month. That's why we're all wearing gray for gray matter, because gray matters. It also happens to be Clinical Trials Day, not just for brain tumors or cancer, but for any illness. That is how we have come to where we are now. That's how we've made the advances that we benefit from now. And that's how we'll move forward in the future. And we'll, I hope, show you some of the things that we're doing in the neuro-oncology program at VCU Massey in that regard. So it's wonderful to see new friends, those who know us well. What we've done is pre-recorded a presentation. It will start with Robin Boyceau, our administrative assistant and patient advocate, and then presentations from myself, from Dr. Zijan Chen, assistant professor of neurology and neuro-oncologist, from Dr. Alicia Zoukas, assistant professor of neurology and neuro-oncologist, and Dr. Ashley Logan, a neuropsychologist, who you should know has just been promoted to associate professor. She just got the letter from President Rao yesterday or the day before. So congratulations, well deserved.
Yes.
So we'll be sharing a recorded presentation, and then there will be an opportunity for you all to answer questions. Submit them to the chat box, and Catherine Layton from the Development Communications Office will oversee the chat box, and she'll direct the questions appropriately to us. We'll also be sending you at the end an engagement survey. Yes, another survey. But this is the first time we're doing this. We want to know if we're doing what you want to hear. We want to know how we did. We want to know what you might want to hear the next time. So please take a moment to fill that out and send it back. I think for those of you who can't or weren't able to make it this evening, this will be recorded, and we'll put it up on the Massey website for the future. Leslie Altaffer, also of the development team, will be monitoring the event, so that she'll be letting people in so we don't get any Zoom bombing going on. I think that basically covers it. Particular thanks to Cindy Zilch of the Development Office, who, with the assistance of Robin, spent a great deal of time and effort putting this together. And so much of what I anticipate will be a successful event is due to all of her hard work. So thank you, Cindy.
Well, thank you, Dr. Malkin. And we will turn it over and start the presentation. Thanks, Leslie.
My name is Robin Boyceau, and I am the Administrative Assistant Patient Advocate for the Neuro-Oncology Group here at VCU Massey Cancer Center. I am very excited to be a part of this program today. As I have always said, we have so much to offer here at VCU Massey, and the Virginia community needs to know more about it. My husband, Sanford Boyceau, was diagnosed on March 9, 2016 with glioblastoma. We ended up here at VCU after visiting many other institutions such as Duke, UVA, Hopkins, and VCU was the only one at the time that had a clinical trial for first-time GBM patients. Sanford had a brother that passed away from glioblastoma when he was 27 years old, so Sanford kind of knew what to expect. On our first visit to VCU to see Dr. Malkin, Sanford told him that he knew he probably was not going to live through this, but he wanted Dr. Malkin to find something in him that could help save someone else. And he meant it. Because before he passed away in May of 2017, he told me the same thing. When this is over, I want you to continue this fight. Get up every day, choose joy in your life, and make a difference in the world of brain cancer. As a caregiver, I had no idea what that journey would be, but I was determined to try my best to figure it out. I started working with the Neuro-Oncology group in November of 2017 and joined the National Brain Tumor Society also in 2017 to help start a race here in Richmond to raise funds and awareness for brain cancer research. I am now in my 4th year and have co-chaired the event for the past 3 years. We have raised over $300,000 and look forward to many more years of success. I am so proud of my committee, some of which are here on the call tonight, and especially my co-chair for this year's event, Kristen Spain. If anyone would like to join us this year in the virtual RVA 5K, please feel free to reach out to me for any information. Now, just a little housekeeping before we get started. Please mute your microphone during the presentation, submit questions through the chat box, and if you experience any difficulties hearing the presentation, please mute your cameras. I would like to now introduce you to Dr. Mark Malkin, the Division Chair of our Neuro-Oncology group. But before I go, I have one favor to ask you. I ask you to join me. Join us here at VCU Massey Cancer Center. Get up every day, choose joy in your life, and make a difference. Make a difference in the world of brain cancer.
Good evening. It's a pleasure to be with you this evening, and we really appreciate the time you have taken to hear what is going on and what we plan in the near future for the Neuro-Oncology program at Massey Cancer Center. My name is Mark Malkin, and I'm the director of the Neuro-Oncology program at Massey Cancer Center and the William J. Reynolds Jr. Chair of Neuro-Oncology at VCU and Massey. I'd like to spend the next 10 minutes or so talking to you about 2 new clinical trials which we will have open to enrollment next month. The first, called NRG-BN007, is a randomized Phase 2 and Phase 3 study of Yervoy and Opdivo in patients with newly diagnosed unmethylated glioblastoma. The NRG is one of the National Cancer Institute's cooperative groups to which Massey Cancer Center has belonged for many, many years. This is an immunotherapy study for glioblastoma. In the past, many approaches to immunotherapy in glioblastoma have been disappointing, possibly because glioblastoma, unlike melanoma or non-small cell lung cancer, doesn't produce many antigens, which is to say abnormal proteins which create an immune response. We are hoping in this study, since patients will be simultaneously receiving radiation therapy, that we can gain more benefit than has been seen in the past. So there are 2 phases to this study. In the Phase 2 portion, we ask the question, in patients with newly diagnosed unmethylated glioblastoma, if we add Yervoy and Opdivo to radiation therapy, do we significantly prolong progression-free survival, the time until tumor recurrence, compared to the usual addition of Temodar, chemotherapy, to radiation therapy? And in the Phase 3 portion, we ask, if we add Yervoy and Opdivo to this population of patients, do we significantly prolong overall survival compared to the usual addition of Temodar to radiation therapy? Here's the study schema. The first step, following surgery here at VCU or elsewhere for patients referred to us, tissue is sent to a central pathology laboratory at NYU Medical Center in New York to confirm the diagnosis of glioblastoma and to confirm that the MGMT status is unmethylated. Patients are then registered in step 2 and are randomized, which is to say a computer at the National Cancer Institute flips a coin, and patients are assigned either to arm 1 or arm 2. Arm 1 is the standard radiation therapy with simultaneous Temodar, followed by monthly Temodar. The Optune device is allowed in this arm. And in arm 2, the experimental arm, where radiation therapy is combined with Yervoy and Opdivo, followed by Yervoy and Opdivo. Optune is not allowed in this arm because there is some concern that Optune may actually interfere with the immune response to therapy. Here is the treatment plan. You can focus on the chart at the bottom of the slide. In the experimental arm, patients get 6 weeks of radiation therapy, which is standard. The Yervoy is given every 4 weeks for a total of 4 doses, 2 during radiation therapy and 2 afterward. And the Opdivo is given every other week during radiation therapy and afterward until such time as the tumor recurs. In the standard arm, patients get radiation therapy with daily Temodar, followed by monthly 5-day cycles of Temodar. The second study, which I wish to tell you about, is also a National Cancer Institute cooperative group study called EAF 151 from the ECOG Akron group. Again, a group to which Massey has belonged for many years. The principal investigator will be my colleague, Dr. Alicia Zoukas, and the purpose of this study is to evaluate whether perfusion MRI can predict an early response to Avastin in patients with recurrent glioblastoma. So patients with glioblastoma, when they have an MRI, receive 2 doses of contrast, the standard contrast and the perfusion contrast. With standard contrast, the picture on the left, the dye leaks through the blood-brain barrier and outlines the position and the size and the shape of the tumor. With the second dose of contrast, perfusion, we are measuring blood flow into the tumor, and you can see on the middle picture that the tumor toward your left side has a very robust blood flow. It is alive. The blood flow is driving the growth of the tumor. Part of the tumor toward its right side doesn't have any blood flow. It's actually dead. But this is the typical picture on perfusion of a recurrent glioblastoma. Our colleagues at UCLA demonstrated in a small study several years ago that perfusion MRI may better predict response or lack of response to Avastin better and sooner than standard contrast MRI. The top 2 rows show us a patient with a recurrent glioblastoma. The top row leftmost picture under T1 plus C shows their tumor before Avastin, and the MRI slice below that shows their tumor after Avastin. And indeed, the amount of contrast is less. If we go all the way over to the right of this slide, in the top row, under RBV, you can see that triangle of increased perfusion. And right below that, you can see that the triangle is smaller and that there's more turquoise and less red, showing us a favorable response to Avastin. And in fact, this patient lived for 638 days. The lower 2 rows show another patient with recurrent glioblastoma. On the left side, pre-treatment, you can see 2 nodules of recurrent glioblastoma, and in the picture underneath, it looks as if those nodules have gone away. But if you go all the way over to the right, under the RBV column, you can see, in fact, that the perfusion hasn't changed pre-treatment and post-treatment with Avastin. In fact, the whole area is a bit bigger, and it's going from blue to turquoise, the wrong direction. This patient, unfortunately, only lived 79 days. So in EAF 151, we will take patients with recurrent glioblastoma. They will be registered. We will do a baseline standard and perfusion MRI, S0 in this diagram. We'll give them a dose of Avastin, and then 12 to 25 days later, we'll repeat the perfusion MRI, S1, and use that before even the second dose of Avastin to try to predict how long the response to Avastin will last. If the response is good, then it would be logical to continue Avastin. But if the response is not good, then it would make sense to stop Avastin and switch to a different chemotherapy or a different treatment altogether or to a different clinical trial. Altogether, 146 patients nationally will be put on this study. And as I mentioned earlier, Massey will be participating in this. It's been a pleasure speaking with you. I welcome your questions during the question period afterward about these two clinical trials, or really about anything involving the neuro-oncology program at VCU Massey. Thanks so much for your attention.
Hello, everyone. My name is Zijian Chen. I'm one of the neuro-oncologists here at VCU. Today, I'm going to briefly talk about one of my clinical research focuses is chemotherapy-induced peripheral neuropathy, CIPN. With the latest cancer research advance, chemotherapy is prolonging the cancer patient life. Cancer is becoming a chronic and a manageable disease. That's why CIPN is estimated to occur in 30 to 40% of our cancer patients undergoing chemotherapy. Peripheral neuropathy is the most common clinical neurological syndromes caused by chemotherapy, and actually is the second most common complications from chemotherapy next to hematological complications. More than 400,000 patients develop the CIPN annually at the cost of approximately $2.5 billion per year in United States. The peripheral neuropathy results from damage to the axon, myelin sheath, or cell body itself, but the pathogenesis of CIPN is still not completely understood. The pathophysiology of CIPN can be more complicated than other type of peripheral neuropathy, such as diabetic neuropathy or vitamin deficiency neuropathy, because of the different chemotherapeutic agents, as well as different location of the injury. These figures briefly show us the different chemotherapeutic agent and the different site of the injury location. Here you can see the dorsal root ganglia, the mitochondrial, the ion channel, and the microtubule, and the very distal nerve terminals. Those are all the different locations of the injury. Chemotherapy-induced peripheral neuropathy is very debilitating and affected greatly on patients' quality of life. CIPN may also result in dose delay, dose reduction, or change of the treatment plan. CIPN also affected the patient psychologically for their mood and quality of life. And treatment options for CIPN are very limited. So that's why early recognition and the prevention are essential. The clinical presentation of CIPN is kind of similar to other type of peripheral neuropathy, which is a stocking and glove distribution. The CIPN affects the lower extremity more than the upper extremity, or earlier in the lower extremity than the upper extremity. The CIPN normally affected the distal part of the limbs first and gradually upgoing to the proximal part of the limbs. The comorbidity for CIPN include endocrine disease such as diabetes, hypothyroidism, infectious disease including HIV, Lyme disease, and hereditary disease such as Charcot-Marie-Tooth syndrome, and etc. Unfortunately, currently there's no definitive way to prevent or reverse the CIPN. The most important thing we can do is educate patient, assess the patient comorbidity to lower the risk of CIPN. And recognizing and treating the persisting condition that put the patient on high risk, and frequently assess the patient during the treatment is the key. The pharmacological management of CIPN include first the chemotherapy manipulation, like the dose reduction, ceasing the neurotoxic agent, and the pharmacological treatment of CIPN symptomatically, including antidepressant, anticonvulsant, especially the gabapentin, pregabalin, and some topical analgesics. Currently, the only FDA-approved medication to treat the chemotherapy-induced peripheral neuropathy, to be precisely, is the CIPN pain, is duloxetine. The brand name is Cymbalta, based on a large-scale phase 3 clinical trial result. The non-pharmacological management for CIPN includes acupuncture, assistive device, and interventional pain measures such as TENS unit and scramble therapy, as well as relaxation methods. Chemotherapy-induced peripheral neuropathy is one of our clinical research focuses at our Department of Neurology and our Division of Neuro-Oncology here at the VCU in the Massey Cancer Center. Here are some of the undergoing clinical trials and the upcoming clinical trials at the VCU and the Massey Cancer Center. This is a investigator-initiated clinical trial based on the science developed at our pharmacology department at VCU by using nicotine patch to treat the neuropathic pain of CIPN. This is a Alliance cooperated group clinical trial by using duloxetine, which is Cymbalta, to prevent oxaliplatin-induced chemotherapy-induced peripheral neuropathy. This is an undergoing clinical trial sponsored by a pharmaceutical company for CIPN natural history study. It tests the assessment tools and collects the serum biomarkers for optimizing the future standard for CIPN clinical research. This is the upcoming NCI R1 grant-funded small multi-center clinical trial by addressing the CIPN clinical care model changes and see if it can significantly improve the outcome, such as ED visit and falls and etc. Thank you very much for your listening. I'm happy to answer questions.
Hi, everyone. I'm Alicia Zoukas, and I'm a neuro-oncologist at VCU, the fellowship director and the neurology clerkship director for the medical school. I'm actually really passionate about inspiring students and new doctors to pursue neurology and neuro-oncology. And you might not know this, but VCU is pretty unique from a training standpoint with exposing students really early to neuro-oncology. We get them thinking early, and we get them rotating with us as early as their third year of medical school, which is unique for a medical school really anywhere in the country. So in case you don't know, just basic medical education, typically the first and second years of medical school are book learning, learning the basics, learning the science. And then the third and the fourth years are when these students are doing their rotations. So this might be when patients meet them at the doctor's office or in the hospital. We also have neurology residents rotating with us. Our residency program has about 24 residents. And of course, we have fellows rotating with us with the Hematology Oncology Department. And we do have a fellowship opening at VCU now in Neuro-Oncology. One thing that is unique about VCU in the School of Medicine is that the medical students can actually rotate on neuro-oncology as their neurology requirement. So it is actually part of their core training. We typically have 25 students per year. They do 2-week rotations with us. And we have roughly 6 neurology residents doing electives with us also. Every single Hem-Onc fellow rotates with us and learns how to treat brain tumors. Our neuro-oncologists are some of the top-rated teachers in the institution. They are certainly the top-rated teachers in the neurology department. Dr. Malkin got Best Teacher Award last year. I think I got it the year prior. Dr. Chen is a renowned teacher as well. I'm sure that you guys already know this, but VCU is actually a really good medical school. And we're fortunate that our students perform in the top quartile of the entire country of medical schools when it comes to neurology knowledge. All VCU students do a neurology clinical clerkship. So every single one of them comes through, and during their preclinical years, they learn the basics and how to talk to a patient. But during their clinical years, that third and fourth year, that's where they really get to meet patients and practice what they've learned. I included some pictures here of our students doing lumbar punctures on simulations, and 100% of our medical students do simulations on just about every neurological procedure before they ever do one on a patient. One thing that I had noticed, and it's probably because of my background in oncology, was that the students didn't really know how to talk to patients, or it was a bit awkward for them to talk to patients in giving, sad or negative news, giving bad news. So I developed a learning module, and every single student who comes through on their neurology rotation, which means every student through VCU, will learn how to give compassionate news, give compassionate bad news, and they will practice how to do that on a standardized patient. And that standardized patient is trained to give them feedback, provide an evaluation for them. And the student will also be able to watch themselves after the fact so that they can work on their news delivery to patients, because I think maybe we've all encountered a medical provider who gave us information in a way that didn't feel good. And there's a way to talk to patients. If you're giving them devastating news, there's a way to talk to them in a compassionate, meaningful way so that they feel heard and they feel like they have all of their questions answered in a comfortable environment. Another unique aspect about our program is not only do the learners learn how to treat patients with brain tumors, they also learn how to treat patients who have complications from a different underlying cancer or complications from a chemotherapy or radiation treatment that they have been receiving. Uniquely, all of our students who rotate become certified to treat CAR T-cell patients. So CAR T-cell therapy is a fairly new, unique therapy offered through the bone marrow transplant department, but it does have neurotoxicities associated with it. So we get our students, and every single resident is trained to treat these patients with whether it's seizure medicines or steroid medicines or anti-inflammatories, something to help get them through their CAR T-cell treatment, because a CAR T-cell treatment can potentially put a lymphoma patient into a very long remission. It's a very highly effective therapy, and we want to help make it work with bone marrow transplant. So you might see these learners in the clinical environment. We do a ton of bedside teaching, both on the inpatient basis and in the outpatient clinics, but we also provide case-based didactics to all of the students. So the medical students, when they're on the rotation, have Friday didactics, and they receive dedicated learning about how to treat patients with brain tumors or complications of their chemotherapy. The entire month of February is reserved for the neurology residents to hear about neuro-oncology. And the hematology oncology department also has a lecture series that we do regarding how to treat patients who have brain tumors, different types of brain tumors, first line, second line, third line therapies, what's the latest and greatest in research. We talk about our clinical trials. And we also have students who join us in our brain tumor board. So we've got weekly brain tumor board, which is a learning opportunity that all students and residents and fellows are welcome to join in on. We do have a fellowship position currently available, and we are interviewing for that now. This would ideally be for someone who is completing a neurology residency. They would spend 1 year doing about 70% clinical work and 30% research, and the research of their choosing. And then in the second year, they would do about 30% clinical work, meaning seeing patients in clinic, seeing patients in the hospital, and spending 70% of their time doing research. At the end of their fellowship, they will have had about 1,000 patient encounters and robust research experience. There are only 35 fellowships in the country, so only 35 locations where someone can do a neuro-oncology fellowship. At the end of this fellowship, they will be certified, board eligible, be able to take their neuro-oncology boards. All three of us have taken our neuro-oncology boards, and we're excited for this fellow to present and attend at national and international conferences. The fellow is able to create their own clinical trials. And we really want to encourage that person to do whatever is interesting to them. How do they want to move the field forward? Through lab work, clinical trials? Do they want to do cognitive research? Or do they want to be an educator, move the field forward in educating others? And they will get 100% supervision by us, by board-certified neuro-oncologists. So I am really excited to hear from you. If you have any questions for me or questions about medical school or training, residency, fellowship, our pipeline, how do we inspire college students, high school students to think about becoming physicians, or to think about neurology, or to take that even the additional step to think about becoming a neuro-oncologist. I'm happy to tell you about my journey, and I'm sure everyone else is too. Thanks for listening.
Hello, everyone, and welcome. My name is Dr. Ashley Logan, and I'm the clinical neuropsychologist on the Massey Division of Neuro-Oncology team. My role is to help support the quality of life and cognitive capacity of our brain tumor patients. Today, I'm excited to speak to you about our ongoing research at the Live Now Lab. We are currently exploring emotional well-being following a brain cancer diagnosis. Our first goal was to examine the current literature and understand what is known to date about the distress in brain tumor patients. We found that emotional distress is exorbitantly high. In fact, over 90% of patients report symptoms of depression, with 30 to 40% meeting criteria for a clinical diagnosis. In my clinic, I see a range of emotions following diagnosis and throughout the treatments, including an initial denial, sometimes turn to anger. I see sadness and even isolation from those they love. And I always see this underlying anxiety, fear, and worry about what the future holds. It's not surprising that brain cancer patients are at risk for emotional distress due to many factors. First, there is almost always a certainty of tumor progression. Second, though our scientists are working hard to find a cure, none has been found to date. And finally, there is a significant impact of the disease and treatments on our patients' quality of life. And unfortunately, to date, there is no standard of care for supporting the well-being or quality of life in neuro-oncology. Our next goal was to examine the areas of distress in our patients here at Massey to see where we needed to focus our attention. Here's what we found. 44% of our patients reported depression, and 36% report anxiety symptoms. We are some of the first to explore the following two distress constructs in brain tumor patients: fear of cancer recurrence and death anxiety. Mild fear of cancer recurrence is considered a normative and rational response, and it usually improves over time. However, moderate to severe fear of cancer recurrence can perpetuate dysfunctional behavior, including avoidance patterns, hypervigilance for symptoms, and an inability to plan for the future. In our patients, 90% indicated at least some fear of cancer recurrence, with 30 to 40% reporting moderate to severe levels of distress. Another distress construct, death anxiety, refers to the fear and preoccupation with thoughts of death and dying that may interfere with an individual's daily functioning. 66% of our patients indicated at least one symptom of death-related distress, with 48% reporting moderate to severe distress. Our final goal was to find an intervention which could support and possibly relieve this distress in our patients. After much searching, I found an intervention called Managing Cancer and Living Meaningfully, better known as CALM. This intervention was developed by two psychiatrists and palliative care experts from the University of Toronto Princess Margaret Cancer Centre. CALM was designed to specifically address the inevitable challenges patients with advanced cancer face. CALM is a brief, individual talk therapy where patients meet with a CALM therapist for 3 to 6 sessions. There are 4 domains of CALM, which represent what research has shown to be the most important and relevant factors to advanced cancer patients. The 4 domains are symptom management and better communication with healthcare providers, understanding changes in yourself and in your personal relationship with others, exploring spirituality and finding a sense of meaning and purpose in your day-to-day life, and finally, exploring the future, maintaining hope while accepting mortality. All domains are addressed, but the patient is free to place the emphasis on whichever domain is most relevant to them. Caregivers are also encouraged to participate, as we all know cancer is not an individual, but a family disease. CALM has been shown to reduce depression, and death anxiety. However, patients with brain cancer were purposefully excluded from all of the trials examining CALM's efficacy. I'm proud to say that I challenge this exclusion. I believe that our patients can also benefit from these services. So, I spent the last 2 years training under the developer of CALM, Dr. Gary Roden, and I have become the first certified CALM therapist in the United States and the only CALM therapist globally providing care to brain tumor patients. So, what are we doing now and where are we going in the future? Last year, we were funded by Massey and the American Cancer Society to begin exploring CALM in brain tumor patients. We are currently about 3/4 the way through our first small proof of concept trial. Results are extremely promising, with a high recruitment rate, a reporting of extreme benefit from those who have finished the treatment, and a solid signal showing reduction in distress. I am also proud to announce that we were awarded a large grant from the Department of Defense to continue exploring CALM in brain cancer, both in patients with primary brain tumors and in those with brain metastases. This award will fund the CALM project for the next 4 years. We are currently exploring funding options to adapt and bring fear of cancer recurrence interventions to Massey. In summary, I want everyone to know that quality of life matters at Massey, and it is my personal goal to help reduce the distress and burden our patients experience while managing life with a brain tumor. Thank you to our amazing patients, my wonderful Live Now research team, and the generous funding support we have received to do this very important work.
Thank you all, and for sharing such a comprehensive approach that you all have, and clearly you work so passionately and collaboratively. I'd like to open it up now for the questions and answer, and Catherine Layton, my colleague, will help address them.
Yes, hello everyone. Thank you again to you all for presenting and for attending. We have a couple questions, some that came to me directly and some that are in the chat. So I'm going to share those. But anybody who is on the call, if you're more comfortable unmuting and turning your video on if it is off and asking a question the old-fashioned way, please feel free to do that. That works too. So the first question we have is, why are glioblastomas so much more deadly than other kinds of brain tumors? So who wants to take that? And be sure to unmute when you go to speak. It looks like most of you are muted.
Well, I'll take a crack at that. The most succinct answer is we don't know. We will get there through basic science research to help us understand the genetics that drive glioblastoma compared to the genetics that drive other cancers. One of the challenges in many solid tumors, glioblastoma, non-small cell lung cancer, prostate cancer, breast cancer, is that there are many abnormal gene mutations, any of which can drive the growth of the tumor. And so targeted therapy to reduce the activity of one gene mutation can result in increased activity of another that can continue to drive the growth of the tumor. So that treatment is kind of like whack-a-mole. It's very frustrating. Whereas in some malignancies, and chronic myelogenous leukemia would be a good example, there's really only one driver mutation. So if you find a drug like imatinib for chronic myelogenous leukemia, you can put the vast majority of patients into complete remission and cure very quickly and for a sustained period of time. So that's one of the big challenges. The number of driver mutations in glioblastoma, and those mutations can evolve over time. So what was there at diagnosis may be very different at recurrence. The other phenomenon that we're getting a better understanding of is what's called the tumor microenvironment, and how factors that we don't understand render our immune system unable to get rid of glioblastoma when it arises. And there may be factors in glioblastoma itself that shut off the immune system so that we can't protect ourselves against tumor growth. And hence the effort that I illustrated in the first part of my presentation to try to figure out how to manipulate the immune system for a better response. So those are some ideas, and I'll let Zijan or Alicia chime in if they have other thoughts on why this has been so challenging.
Yeah, I agree, Dr. Malkin's comment. One I want to add it on is the hurdle of the drug delivery, because of the this called the blood-brain barrier, which block the therapeutic agent to get into this glioblastoma or glioma. Basically, our understanding is like almost like a 95% of the current available chemotherapeutic agent cannot cross this BBB to get into the tumor to kill them. So this is a major hurdle we haven't overcome yet. We've tried different ways, like the convection enhanced delivery, or manipulating the blood-brain barrier by osmotic, osmolarity changes, or some like a ion channel blockade or something to do that. But so far we haven't had any major progress to solve that problem. So that can be the future, or as already a lot of effort has been put on that to overcome that.
Let me give my 15-second thought process about this. Imagine you're on a beautiful black sand beach in Hawaii, but you're holding a handful of white sand and you throw it out into the beach. So that's kind of like glioblastoma. You've got the main ball of sand that lands on the beach, but then you've got all of this scatter, and you've got this microscopic invasion of scatter that you just cannot surgically pick out, and there's no marker on it that you can target either. So you can't surgically remove it because it's so microscopic, pieces of sand that are almost impossible to identify from other pieces of sand. And that approach has actually been made. Can a neurosurgeon actually go in and microscopically remove these? And that has not been successful so far. So it's just from a surgical standpoint, it's impossible to debulk that sand, those tumor cells from the brain.
Thank you very much. In follow-up, the same person asked, what does, and forgive my pronunciation, what does methylated mean in brain tumors?
I can take that one. When I saw that question in the chat room, I pulled out a presentation. Now, I can share my screen, or if I can share my screen, let me see. Am I allowed to do that? Can I do that? Here, share screen. Here it is. Share. Can you all see that?
Thank you.
Yeah. Okay. So all of our cells have genetic material, DNA in them, the normal cells and the tumor cells. So in glioblastoma tumor cells, on chromosome 10, there is a gene which codes for an enzyme called MGMT. methyl guanyl methyltransferase. MGMT is also the name of a rock band. And the gene for MGMT codes for a protein, this methyl guanyl methyltransferase, MGMT. And this protein is what we call a DNA repair protein. So if the genetic code in the tumor cell is damaged, then this repair protein can fix the damage. So here is guanine, a chemical in the DNA of the tumor. We give the glioblastoma temozolomide, and it sits here on an oxygen molecule in the DNA of the tumor. If the MGMT in the tumor is unmethylated, then this DNA repair protein is made, and it knocks the temodar off the tumor DNA. So now the tumor DNA is normal. And if tumor DNA is normal, one cell can become two, and two can come before. And this is tumor progression. This is tumor recurrence. This is chemoresistance. However, if the MGMT is methylated, then the DNA repair protein's not made. So then, if we give the patient temodar, the temodar sits on the tumor DNA. And when that happens, the tumor DNA can't replicate, and the tumor can't grow. And so we can actually measure in the lab, the turnaround time is about 2 weeks after a biopsy, whether it's methylated and we know the patient's going to respond, or whether it's not methylated and the tumor's going to grow. It's what we call a prognostic test. Temodar is the standard therapy for glioblastoma. We're going to give glioblastoma anyway, but at least we'll know early on, a priori, how long it's likely to work. And so our radar are turned on to start looking for other options, especially if it's unmethylated. Let me stop sharing.
Great, thank you. So the last one in the chat to everyone, it is so impressive to hear of your neuro-oncology advances and how you work as a collaborative team internally and externally. I'm curious how you navigated the challenges of the pandemic to care for patients, and this can go to any or all of you.
Why don't we ask Ashley to take that one? Because I think her team had to adapt more than anybody else.
Yeah, that's a great question. So again, the nature of my job is to provide cognitive assessments. And so we have all of these tasks that we have patients do to assess their memory and their thinking and their attention. And they require, or historically have required, face-to-face interaction for multiple hours, like 3 to 6 hours. And so when the pandemic hit and we were told you can't see patients in person, you can't touch anything, we had to completely halt and redesign our clinic so that we can continue to care for our patients. So we met with people up at MGH, we met with people over at MD Anderson, and we all got together as a group to figure out what tests we could transform into a virtual world and what tests we couldn't. So we spent about a month coming up with a whole new battery of what we could adapt for the virtual environment, and then was able to reopen our clinic and provide virtual evaluations. Shorter, more abbreviated, because again, some of the tests just can't adapt. I would have to send a whole kit home to every patient. But we were able to provide still care through the crisis. And then as things eased up, we're now continuing to provide virtual services by patient preference. So we will call the patient a week before and say, would you prefer to come in person and have the extended battery and the usual care? Or would you prefer to stay at your home because you're either high risk or it's 2 hours to travel here and it's just easier for you to be in the comfort of your own home? So we're able to now provide both. And I think my wait list would tell us that we're providing more services than we ever have before because we're reaching more patients this way. So a crisis actually turned into an amazing thing for our clinic.
Great. A follow-up question for you while you are unmuted or can re-unmute. The question is, congratulations on becoming the first certified comm specialist in the United States. That is wonderful, and kudos to you.
Thank you.
Can you share more about the response at Massey in terms of patient volume for such critical quality of life care?
Yes, thank you. So I think the response has been great. Again, the trial that we're doing right now, we have a 91% enrollment recruitment rate. So people are open to this idea of talking about these challenging topics, wanting support with quality of life. I also have a large lab that includes graduate students. So what we do is we offer practicum positions to doctoral graduate students, kind of like Dr. Zukis was talking about for the med students, but we do it for psychology students. And I usually have 3 to 4 students rotating with me every single year, and most of them stay on multiple years. So last year, because I had such a large cohort of trainees, we brought Dr. Roden, who was the developer of COM, down to VCU to give us a personal and special training to get us all up and running on the COM program. And actually, not only did my trainees and my team come, but all of the physicians that have spoken to you today joined us as well to learn about the therapy. And Dr. Roden told me he has never had that before. He said usually the physicians are off to the side and they just, tell the patients to go see the psychologist, but it really spoke to him that all of our physicians wanted to know what we were doing, how we were doing it, and be involved in the care. And so right now I have 3 trainees that are going through the certification process. One next month is going to be the 2nd certified comm specialist. And then the other 2 probably have another 3 to 4 months to go. And then we will have multiple comm certified therapists at Massey.
Wonderful.
Well, I was just going to say, we're just right at our close, unless there's time. Do you have one other question, or are you?
I do. I have a couple more questions, but let's do one. And if others have submitted questions, we will do our best to follow up with you with an answer. So doctors, we may be sharing some additional questions with you, and appreciate your indulgence in getting answers to our folks. The last question is for Dr. Zukis. Your passion to inspire students to pursue a career in neuro-oncology is wonderful. That's not the question. Here's the question. Please share more about your pipeline efforts. Specifically, how are you working with college students and those younger to encourage interest? And I would follow up to that. What is your elevator pitch? Why neuro-oncology?
So the pathway to neuro-oncology is through neurology. So we have to get them through neurology first. I mentioned in my talk that we have hematology oncology fellows. So there are oncologists who practice neuro-oncology as well, but the pathway now is through neurology. So we have an active sign group, and what a sign group is it's an acronym, and it stands for Student Interest Group in Neurology. And what this means is we talk to first students who are 1st year and 2nd year medical students, and we have neurology interest topics. And something that I like to talk about are like the neurotoxicity of witchcraft, like going way back in time, back to the 1600s, go back to the Salem witch trials and go back to what was the neurotoxicity that they were describing, and just try to instill that interest in neurology first. Was it a paraneoplastic? Was it actually a cancer syndrome that those witches were experiencing? Just like make them think. And we, in that student interest group in neurology, we also go out and do outreach in the high schools. So we go to local high schools and just do some interest topics on the brain, and that tends to be led by the residents. I feel like I took up too much time with that answer. If you have any more questions about that, I'm happy to answer. We also have people who shadow us. I typically get about 15 requests per month from undergraduates who request to shadow. I can't honor all of them. And during the pandemic, we've not been allowed to honor any of them. But we've had a handful over the past couple of years in neurology clinic for sure. I think I had one or two. I had two in neuro-oncology clinic.
Great.
I just want to
Thank-
add my thanks to everyone. I don't, Dr. Malkin, do you have any closing remarks before we all leave?
Good here. No, other than to say thank you for everyone who helped organize this, participate in this. I really found this very valuable. Those of you who know me know that I could go on here all evening, but I think that would be selfish. And the Toronto Maple Leafs are playing the Montreal Canadiens, and at a certain point, certain things take priority. But thank you all so much. Yes, for those of you who have questions that weren't answered, they'll get routed to us, and we'll call you or email you and try to answer. And we look forward to doing this again. I thought it was a lot of fun. And because we'll make progress, there'll be new things to talk about next time.
Great. Thank you all very
Great
much.
evening. Mhm.
Good night.
Thank you.